All right, welcome everyone. We have Dr. Micheal Gerling here, who is the site director of spine surgery at NYU Langone and an associate professor at NYU. He is board certified in orthopedics and has done a prestigious fellowship in spine surgery and is a specialist in not just minimally invasive approaches, but endoscopic approaches in spine surgery, which is kind of the cutting edge of the surgical world within spine. So really excited to have you here today. Dr. Gerling, any other intros, or did I get it there?
No, thanks for having me. It's a real honor.
Wonderful. So we had another video earlier where we discussed kind of the, what are the benefits and the differences between minimally invasive and endoscopic. So you can check out that video for more of a robust overview of kind of what it is, the benefits, why we do it, but today we're going to get into how we do it. So this is more of a procedural chat today, because I think a lot of people are curious in what exactly is the instrumentation that you use, what is the procedure from start to finish for a discectomy, for a decompression, for a fusion. So you kind of walk us through what that looks like from a procedural standpoint.
Sure. I can send you some images as well. And also if people Google the different types of camera systems, you'd be able to see representative images of it. But the bottom line is that what we're able to do is create a portal from the skin to the target, whatever the target is. And as we discussed in the prior video, that target could be inside the knee, it could be something inside the belly. A lot of OB-GYN procedures are done with cameras and laparoscopes and whatnot now. And the same thing is true in spinal surgery. So once we have established a target that we want to treat, for example, a disc that's herniated and it's pressing on your nerve, a spur of bone that's pressing on a nerve, or some other structure like a cyst that we want to remove, we essentially take different imaging platforms like an MRI or a CAT scan and x-rays, and we kind of take that clinical picture. We determine exactly how we're going to approach the target, and then we would use a camera during surgery in order to visualize our path and in order to sort of plan our procedure. Now, the patient is under some form of anesthesia whenever we're doing a procedure, and that may include medications that are similar to what you'd get for a colonoscopy or other minor procedures. If you were having a cast put on, if you had fractured your leg, oftentimes in the emergency room, they'll give you something called conscious sedation, which means you're conscious, so you're actually breathing and able to speak, but you're sedated, whereby you're not going to remember it. You're really not feeling most of it. It's blunted. You're comfortable, basically. And that's the most important thing, is people want to be comfortable. And also, you don't want to be traumatized by just the fact that something is going on. So we give you medications that make you relax and also not remember any of it. So it's just like having a colonoscopy or those other types of procedures where you really need to have some form of medication, but it's not deep anesthesia like general anesthesia. And in some cases, for example, I did several of these yesterday, and one patient wanted to have general anesthesia, and that's okay. You can do that. It's just that it has more impact on you in general, and it does change a little bit the way I do the procedure, but not much. The bottom line is that once we've established our target through our imaging and our diagnosis, and once we've sort of set you up on a table, you've had your anesthesia, and we know our plan, we use cameras during the surgery in order to actually visualize the targets through the body. We call those fluoroscopes. I would actually literally use an object to, with the fluoroscope, confirm what my trajectory will be, because I'm not making a large incision. So my start point, where I start the portal, has to be in line with my target. So we use these nice cameras in order to make our plan. Then we would literally numb up the skin, pass a needle through the tissue and numb up the tissue all the way along that path to the target, so that literally you don't even need at that point to have some type of significant anesthesia, because you won't feel it. feel what I'm doing. And that's one of the benefits of using the conscious sedation, is that if I didn't quite numb up one part of it, you could say, oh, I'm starting to feel that, and I can add some numbing medicine. And so that way, when you wake up from the surgery, almost every single part of the tissue that was touched by the procedure is numb. So it's just like if you left the dentist office and you had some numbing, well, you could go back to work. You might not talk the same because your tongue is numb, or you may not chew the same because your tooth is numb, but you're really tolerating it well, and you can go on with your regular activities right away. It's directly analogous to what I'm referring to here. So once I put that needle down through the pathway, I can actually use a guide wire that goes through that needle and maintains that path. So it's almost like the breadcrumbs with Red Riding Hood. It shows you from the skin all the way to that target. Then I make an incision that's large enough for my portal. Most of the time, my portal is 7 or 8 millimeters in size. So literally, it's like a poke hole. And the scar from that is very aesthetic. It looks like a mole or a small, freckle in some people. Sometimes you can't see it at all because I do the line, the cut in the pathway of your regular lines of the skin, so that it just looks like another regular line on your skin, and it looks like you're just a little crease there. So it's aesthetically very pleasing. But more importantly, once I've made that incision, I put it almost looks like a pen, a type of probe, we call it, that dissects along the path of that guide wire. So literally over the guide wire, I pass this long pen-looking thing that passes between the muscles and literally just spreads them to the side, so that you approach the tissue target with almost no true injury to those muscles, no disruption of ligaments, all the supporting structures that give you stability, the structures that you use with the functionality, the normal function of your spine, which the physical therapist will help you regain the use of with normal surgery. Well, now we haven't even injured that tissue, so that your return to activity is going to be that much easier, and your pain and discomfort is going to be that much less. So once I have that bullet down to the target, I can put a little sheath, almost like a tunnel type channel that goes over that target. And then when I pull out the bullet, I literally have a conduit from the skin to the target. Okay.
Yeah. So at this point, it looks like a big hollow tube from your skin, external to the skin, going all the way down to the site. And that's where you use your instrument. I think just to kind of review here that, and just to make sure everyone is aware, this is a very different procedure. It's not just a different entry to the body. It's a completely different procedure than minimally invasive approach, different tools, different systems, and different technique.
That's right, because exactly as you're pointing out, we do not need to look around our tools and instruments to perform our activity at the target, because we're looking through this camera and we're working through the camera. So we have better vision than you could with any direct line of sight type of surgery. Literally, it is like an IMAX movie of vision of the target. So I can see all of the structures that I need to see in order to perform the procedure. I can accomplish all of the same objectives, but through this incredibly elegant, discreet, very, very practical technique. And another beautiful thing that people don't think about very much is, people are all made differently, and some people are really deep and some people are really shallow. Some people have incredibly thick layers of fat or adipose tissue, and some people don't have any. With this tube, it doesn't really make a difference, because I'm going from the skin to the target through this little channel, and I don't need to make a bigger incision. If I was trying to retract the tissue with a traditional retractor, the deeper it gets, the more it's hard to keep the tissue out of your line of sight, the harder it is to manage the same tools at that depth, because it's so much deeper. And don't forget also, the more tissue you're going through, the more issues with bleeding and all these other types of distractions from the procedure you have. But with this tube that we've created, it's almost like a tunnel from the skin to the target, which you could look through almost like the barrel of a gun, and it doesn't matter how deep it is because the camera just passes through the whole thing. And I am literally working from the end of this camera. My sight is the same, whether you weigh 500 pounds, which I've operated on, by the way, with this camera. People who had been told they could not have a discectomy procedure because they were too big, too deep, that the risks would be so great that it would outweigh the benefits. Operated on those people with the exact same type of tunnel, the same cut, 7 or 8 millimeters in size, as I do with people who are 100 pounds. So, so our ability to target and treat the tissue is not affected by the depth of that conduit, that tunnel.
That's a great point. I think that's great for us, for clinicians to know, because when we're talking about referring to specialists for certain procedures, it's nice to see to identify different patient populations that would not just subjectively and objectively benefit from a specific procedure, but the population and the size of the patient. That's not something that we always think about. So it sounds like this is a great approach for really minimizing tissue disruption in general, and blood loss and recovery time, but specifically for those larger patients where you're gonna have more tissue disruption.
Yeah, and it may be a football player, it may be somebody that is a tile worker that is on their knees lifting tiles all the time, and they are so muscular. You can imagine how much pain and suffering is avoided by not having to cut through and retract those muscles. And some people, because they're so deep, it's challenging, so it takes longer. So you can imagine that you're retracting those muscles for a lot longer too.
Yeah.
Right?
Yeah.
And so there's more death of the tissue. Those muscles have permanent scarring to them that they don't have when it's quicker and when it's more efficient and you have these small conduits. So, that you may sometimes refer a patient for treatment that you would think is a great candidate for surgery, and you get this answer back that, no, the guy told me that I shouldn't have surgery. Well, sometimes that's playing into the decision, and maybe even the surgeon can't communicate or doesn't communicate it very well to the patient, or that it gets lost in translation. So as a referring provider, it may be confusing at times, but this is something where you'll see that there'll be a broader scope of people that can be treated with this type of technology, and don't forget also patients that have other comorbidities, patients that have brittle diabetes and all these different things. These wounds are so small that the chance of having a wound complication or a problem is reduced dramatically. So that's like just one of the many benefits of endoscopic spine surgery.
Yeah, excellent. So speaking of the wound management, let's kind of pull it out toward the end of the procedure now. So now you're closing. What does it look like closing? How do you close? And then after you're done, what does it look like for this patient, 1, 5, 24 hours, 48 hours after the procedure? And then maybe also throw in there to reduce some of the stigma behind getting some of these procedures. Because a lot of people, with failed conservative management, surgery, you want to fail conservative management and pain management before you go to surgery, of course. But when you do go to surgery, some of these are very quick, right? So, maybe we could reduce the stigma of some of these surgical procedures. Walk us through, how long do some of these take? And then what is it like that 24 to 48 hours after these procedures? Because that's something where a lot of the fear comes in.
Of course. First of all, I think that the things people fear are long-term problems and short-term problems. In long-term, people worry about things like nerve damage. They worry about stability of the spine that might be disrupted by the collateral damage. These are things that lead to disability. They lead to pain and suffering. They lead to more surgery, incredible economic losses, and problems that, even social losses, because it's hard for them to socialize, and they may need to be on medications that affect their ability to drive. All these things are incredibly impactful. So those are long-term things people fear, which are obviously minimized when you do something that has less collateral damage. Then in the short term, people worry about some of those issues, for example, the pain and suffering, and how quickly they can return to work, what their restrictions are in the short term and long term. So those are things that all are modified by these smaller procedures. Time-wise, of course, it depends what the specific procedure is. But I can tell you that I did several of these endoscopic surgeries yesterday, and all of them were less than a half an hour of actual operative time, because all of them happen to only be at one level at a time. And sometimes I'll test multiple levels while I'm in there, but I only have to make the cut and actually put the camera down and treat one of those levels. And yesterday it just happened to be that each one of them, I was able to identify one specific target that was a real bad spot. So I actually track how long I'm retracting the nerve and all the tissue in there as well. And I could tell you that, for example, yesterday, the span of time that I spent with my actual camera in there was between 7 and 15 minutes of the actual camera retracting the nerve root, which is well below what we have learned is sort of the threshold where the nerve starts getting irritated or damaged, which is a real blessing. That is, it is a little bit quicker than one would probably have with an open procedure, but not necessarily. Some people that do micro discectomies through the traditional approach do them in a similar time, but a lot of people do it in 3 or 4 times as long, literally. It just depends on the way they do it. But what I will tell you is that once you become proficient at this technology, the wake up time is so much quicker because you're using the lighter anesthesia, and because of the medications that are involved with trying to get you under to tolerate the procedure. Because I was telling you that I do a lot of local injection, the amount of medication they have to give you to keep you comfortable is so much less that the actual anesthesia recovery and the impact of anesthesia on you is going to be that much less. And then beyond that, when you wake up and everything has been numbed up and you only have that small track of tissue disruption, your actual time from the waking up to leaving the facility is minimal. It's less than an hour in most cases. It depends if we're doing a procedure with implants. With implants, we like to give you a little bit more time to recover and to observe you, but not a lot longer. Many people that are on the younger side of things that are undergoing an endoscopic fusion with implants, those patients are going home within a couple hours, and most of the time the same day without having to sleep at the facility. So these can't be done ambulatory. But those patients still are given similar restrictions to what we would give if we were doing the procedure in an open fashion, because I don't want the target tissue to be irritated. I don't want the target tissue to have more problems. I do put lifting restrictions on patients still, just purely to try and get them to think about the fact that they had something substantially done and that they need to protect it.
Yeah. How long do you maintain those precautions?
So I don't want them lifting anything heavy for the first 6 weeks. And when I say that, I know that there are people lifting up their kids, that there are people doing things that are stressing it. I've had a patient that went surfing in Bali within the first 2 weeks after a 2-level lumbar fusion. And he said he had an awesome time and that he was able to do it. But was that risky? Yes, definitely. I would definitely say that he put himself at more risk. But he is a very happy person that is not going to put any challenge to the side, and he's willing to take it. So I think that doing physical therapy, for example, that's another big question of when you should start it, because I think that even with those restrictions, that it is appropriate to start therapy, even if it's just a light home exercise program guided by your therapist. Those are things that can start within the first 2 weeks. As long as people are conscious of the fact that you have a structure that needs to heal, which most therapists are, then I think that it's very safe and appropriate for people to start the rehabilitation process. Now, in the case of the endoscopic surgery, the muscles are not reattached or torn or killed by the procedure. It's more just a matter of mobilizing, because there are natural reactive spasms and reactive symptoms that patients have after any type of surgery. Even if you think about when you get a flu shot, your muscle tightens up because it's a reaction to the fact that something is in there. So no matter how minimally invasive a procedure is, there is going to be a recovery time, and there's going to be a time of dysfunction where having a guiding hand on that recovery would really be helpful.
Yeah, well, we love being that guiding hand. I think that, one of the things is when we're doing some of these post-operative programs, it's just a lot. It's a lot of education. It's a lot of training and proper contraction of the tissue. And then I think there's always a kind of an anxiety overlay. There's always a component, post-operatively about what someone can do, how much can they push it, and I think that I think what you're saying, the idea is you want to have that precautionary period, but just even not we're not throwing people into heavy lifting programs right away. This is just mobility programs, flexibility programs, making sure people are comfortable moving around and contracting and protecting their spine with proper stabilization techniques. So I think further on, past that 6-week part, and then I think it's important to progress with that more profound lifting, teaching ergonomic lifting strategies. We don't want this to happen again. We want to make sure that we protect the spine. And I think one of the things that we love to do as physical therapists is arming people with the proper tools. We don't need to see you long term. That's not our goal. We want to train you properly. And the reason, especially post-operative, getting you back into that zone where you're okay to move again.
So a professional athlete would be back on the Stairmaster and on a bike and doing aerobic work in the first 2 weeks after the surgery. And at 6 weeks, they would go back in the gym and start doing actual lifting activities. But of course, I always counsel everybody, that you should start light and really slowly build up your strength. Really be cautious beyond what you normally would have been if you didn't have surgery. But, a lot of professional athletes have these procedures done and go back to, very aggressive activities quickly. And so that's okay. If you're not making $1 million a year or 10 million or $50 million a year as a professional athlete, you don't have those pressures. So I think that we guide our recommendations based off of what, the person's needs are. We do have a little bit more hands-on approach with people that are in a more precarious situation, such as a professional athlete, people that are construction workers, all those different people that make their living with their hands and with their bodies. So these are things that need to, you should definitely have this guided by professionals that are accustomed to working with these people. You should definitely come to somebody that is very attuned to this type of surgery on those types of individuals. So if it is a precarious scenario.
Yeah, I mean, that's excellent advice. A lot of these professional athletes also have people on them 24/7. They're watching, as they progress them more aggressively. Is there any inflammatory process that's going on? Is there anything that needs to be scaled back, or are you, do you have a green light to push forward? So, we try to do that in physical therapy and kind of help guide you. We're not going to see you 5 days a week, 7 days a week, like a professional athlete is, but we'll see you enough to help guide you and progress you, as you go along in your rehab process. So that's kind of the point. There's, a back's not always a back, an ankle's not always an ankle, right? Everything has their own individualization, post-operatively, pre-operatively, watching a patient, seeing how they progress, and seeing how they're really feeling, and then also taking into consideration some of the cognitive component as well. I think is always important in post-op. So yeah, right on. But yeah, I think that was excellent. I think we covered a lot in that from the procedural. We have another video again that you can check out, learning more about the difference between minimally invasive and endoscopic. And this kind of really zeroed in more on the procedural aspect of endoscopic. And so Dr. Gerling, thank you so much for being here. We're definitely gonna have you back. We've got a couple other things to cover in the future. We got to cover disc replacement. We got to cover some of the other techniques as well. But I think we'll packet that up in some more consumable videos. And so I'd love to have you back soon.
I'd love that. Yeah, there are a lot of technologies that we can review that I think would be helpful for everybody to discuss, and having a multidisciplinary forum whereby we're talking about these things it's surprisingly uncommon. And I think that for the public to have access to them and to actually hear those conversations is even more rare and a real blessing. So I thank you for including me.
Yeah, excellent. And we're going to blast out your info just so everybody knows, Dr. Gerling's website is it's gerlinginstitute.com, right? I think gerlinginstitute.com. And you have locations in little satellite locations in, everywhere. I think you got Manhattan, you got Brooklyn, you got Staten Island, and in Jersey City, right? So
we have 5 providers. Sorry to interrupt, but we have 5 providers in the practice. So that does allow us to have satellite locations. My office, I'm primarily seen in the city in Tribeca, and we're opening a new office at 740 Park Avenue in 2022. It's under construction right now. So we will be available in sort of north and south Manhattan. We do have an office in Clifton, New Jersey, and then we have Queens, Brooklyn, and Staten Island. So we are available, and we are really looking forward to collaborating with you.
Yeah, excellent. So we'll put all your info in the notes below. And if you have any questions, you'll have an email there. You can always reach Dr. Gerling's office and find out a little bit more about the endoscopic approach to spine surgery. So thank you so much for being here, and look forward to chatting again in the near future.
My pleasure. Thanks again.
All right.